Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Welcome to Expert Speaks from Abroad, Saving Lives with Robot with Dr. Naseem Ghazali. My name is Ayman Azlan. I'll be your moderator for tonight. Tonight, we'll be talking about STEM, science, technology, engineering, and math. And if you who are watching this have an interest in using STEM to apply STEM in saving lives, in solving problems, real world problems, then this is the program for you. And before we begin, let us begin with the short speech by our supervisor, Kaila.
Hello everyone. I experienced very bad pain in my abdomen last year, which later on I underwent a minor surgery procedure called colonoscopy to remove polyp, which is an abnormal tissue growth at my colon wall or the large intestine wall. Well, unfortunately, it happened to be a neuroendocrine tumor, which is a rare tumor. But don't get confused. What I would like to highlight here is nowadays, even back in year 2001, there is always a better option to get minor or major surgeries, whether as small as colonoscopy or major as the cancerous case, with something better, which is robotic assisted surgery. Therefore, I understand that most of you have made a huge effort to join our special inspiring event tonight, which entitled Expert Speaks from Abroad, Saving Life with Robots. Therefore, on behalf of Science Department, Police Matriculation College, we are deeply appreciate and offer all of you our most grateful welcome. So as to meet our goal tonight, we have specially invited a robot surgeon expert across the continent, Dr. Naseem Ghazali from United Kingdom, to share with us her expertise, her knowledge, her experience, and her research in robot-assisted surgery. So stay tuned and enjoy the talk from all over the globe. Thank you.
Thank you very much, Puan Azila, for your speech. Now, let me introduce to you our speaker for tonight, Dr. Naseem Ghazali. She was appointed to the Royal Blackburn Teaching Hospitals in July of 2016. She is dually qualified in dentistry from University of Malaya and in medicine from Guy's, King's and St. Thomas School of Medicine, University of London. She specialized in oral and maxillofacial surgery, in head and neck cancer and reconstruction, and in particular, and the topic of tonight, robotic surgery. She has successfully established the head and neck robot service in her current hospital and is the only, let me repeat that, the only certified robot head and neck surgeon in Lancashire, Cumbria, and Manchester. Before we begin and before I pass the floor to Dr. Naseem Ghazali, I have a few housekeeping announcements. First of all, for all the audience who are attending tonight, we have pre-selected a few questions from KMP students from before. However, the comment sections can still be used for your questions. If we have time, we will pick random questions from the audience tonight. So please, if you have questions, write them in the comment section down below, and we will keep an eye on them and pick a few when Q&A comes. Secondly, for those of you who are staff members of KPM, Kementerian Pelajaran Malaysia, you can fill in the attendance form towards the end of the program. It will give you a link, so stay tuned for that, and you have to stay until the end. And lastly, during Dr. Naseem Ghazali's presentation, there will be videos and photos, real photos from Dr. Naseem's experience, and they will be quite graphic. Therefore, fair warning to those of you who may be a bit squeamish, not comfortable with seeing graphic images, Dr. Nasim will tell you beforehand, yeah? And lastly, and most importantly, whenever these pictures or videos are shown on your screen, please do not record, screenshot, taking photos, or whatever kind of recording that you can do, because we want to respect the privacy and the honor of the patients who have given the consent to Dr. Nasim Ghazali. Okay, that's all from me. I will introduce to you and present to you Dr. Nasim Ghazali. Take it away, doctor.
All right. Thank you, Ayman. Thank you so much. I would like to extend my gratitude to the organizing committee at the Science Department, Perlis Matriculation College, in particular, Madam Azila, for your invitation. I'm really very excited and delighted to be here today because I get to talk to you about my most favorite subject, which is robotic surgery. I agreed to do this presentation on a very sunny Sunday, which I normally go cycling, but I'd rather be here with all of you today because I remember what it was like during the times of matriculation, and it can be quite confusing because you don't really know what you'd like to do in your life as a career. And I think it probably relates to an uncertainty about how we feel as a young person, a young adult that's entering the world and taking our lives in our own hands. So as Ayman kindly mentioned earlier on, I'd be very grateful if all of you can refrain from taking photos, videos, of the surgeries that I will show you, because obviously the topic is robotic surgery, and these surgery actually happened in real life. They were my patients, and they've kindly agreed to allow me to show you the surgery that I've done for them for the purpose of medical education and also education in general. So I'll straight away go into my presentation. So window. Here we are. Okay, so let me just get the slideshow on. Okay, so this is where I work. This is Royal Blackburn Teaching Hospital. I'm a head and neck consultant, and I provide head and neck cancer services as well as the robotic surgery services for about 2 million people who live in Lancashire and South Cumbria. We also accept tertiary referrals from the rest of the country regarding robotic surgery in particular, because there are very few of certified robotic surgeons, particularly in the head and neck area. I have, like I said, I don't actually work for Intuitive Surgery, which is the main company that produces the robot, although I have attended some of their programs. And also to mention that I have consent for patients in this presentation. I will try and remind you to look away if you find some of the images particularly disturbing, and hopefully you will have enough time. So in my 45 minutes, I hope to talk about surgery. Open surgery is how we do surgery, and how sometimes it can be damaging to the body in its process of trying to heal, and how there is a shift from open surgery towards minimally invasive surgery, which Madam Azila mentioned earlier on, about better ways, newer ways of undertaking similar procedures, but with less damage, and how that has come to the development of the robot. I will also talk about this in particular relevance to head and neck surgery, which is the area of practice that I work. I will try to explain what the problems are in head and neck surgery, and how the minimally invasive approach, particularly the robotic system, has helped to solve some of these problems, and highlight the applications that I use. So as surgeons, we spend lots and lots of time in the operating room. It's not work, actually, it's quite fun. But at the center of what we do is making sure that the work that we do achieve the highest technical ability and skill and performance, so that we minimize the effects of complications on patients while achieving the aim of the surgery. Okay, so the next picture might be a bit squeamish for squeamish people. So open access surgery is what we do. In order to get to the area of surgery, which can be located deep into the body cavity, we need to cut through normal tissues, which include the skin, this connective tissue, which is immediately the layer underneath the skin. And sometimes we may even need to cut through the bone in order to get to the area of where the disease is. So as a result of doing that, going through the access, we cause damage to normal tissue which aren't actually part of the surgery. So that is what we call collateral damage. And because of the collateral damage, we consider open surgery somewhat invasive for patients. In the head and neck, it's just the area that I work in. There are some problems, which are problems that result from the natural anatomy, from how the things are arranged inside the mouth, the nose, the back of the throat. And the back of the throat and the back is also a shared area between the airway, which is the trachea, and as well as the swallowing part of the body, which is the esophagus. So that area is it's not there isn't a specific boundary as such. It's very continuous. So one area becomes the next area almost seamlessly. And because of that, when you do an operation in one area, obviously it would affect the other areas. The area I work in particularly is the oral cavity, and you can see from the diagram that the oral cavity is separated into much smaller subsites, which is highlighted over there. These subsites are sometimes very difficult to see because the cheek, like the buccal mucosa, which is the lining inside the mouth of the cheek, they collapse inwards, and then the tongue, as you can see, is being pushed over here. To the side, but otherwise the tongue flops and covers the teeth, sometimes covers the floor of the mouth underneath the tongue. And you can't really see the back of the throat because you've got tissues draping in the midline called the soft palate. The tonsil is sometimes tucked away and you can't see that. And it's all made worse when patients have difficulties in opening their mouth fully because of the disease itself and sometimes because of scarring. So in this case, you can see that the abnormality is just hidden over there behind teeth that don't move. And there are lots of shadows, and all these things become a problem because when you want to operate and you want to be able to do the right bit of work that you need to remove the disease, you need to be able to see what you do, and access is obviously the most important thing. So one of the ways that we access this area here so that we can see this area properly is by putting a telescope. So this red line here shows the path of a telescope, which I'm just going to play the video. So the telescope comes from the front of the nose, and the telescope is now running along the floor of the nose, and you can see the structures inside the nose, which you would be able to see normally. And it's now coming to the back of the nose, and you can see the bit down here in the 6 o'clock position movement, which is the movement of your soft palate. And then there's a lot of saliva, which can sometimes block things. And now you can see the vocal cords just behind this bit of tissue here, which we call the epiglottis. And here, in this area here, is this area behind the tongue. So behind here is the vocal cords. So you can see that with the camera, even with the camera, you can't really see because the shadows often obscure our view. On top of that, the area that we work in also involves the neck. So the neck is the communication area between your heart, your lungs, to your brain. So you can imagine that there are lots of major blood vessels, the carotid artery, the subclavian vein, the jugular vein, all of that's in the area of where I operate normally. There's also the breathing pipe, which we talked about earlier on, the trachea here, which is very important. Any swelling at the top inside the mouth can cause compression of the airway and obstruction. And when you can't breathe and if you bleed, then those are the two most important things that allow us to live. So you can see that these risky things make surgery quite complicated in the area where I work. So open access head and neck surgery is highly invasive because you're going to cause a lot of pain afterwards. Because of the feeding and the swallowing tubes being close to the area, sometimes people can't swallow, so you would have to put a tube temporarily for patients to feed afterwards so that they can get the nutrition that's required for healing. We may also need to put temporary tubes into the airway so that patients can still continue to breathe after the operation, seeing that there could be some swelling, bleeding, lots of saliva. As you can see, these things block the airway. Complications can be a real thing for the surgery that we do, and especially with bleeding, seeing that you can see the blood vessels, which I showed you earlier on, the airway, which can be compromised, as we mentioned, and infections. And infections can occur after any surgery, and obviously the mouth being a dirty area with resident bacteria, getting wound infections and spreading through the tissues which we've opened up as a result of the open surgery can be very fast and very, very dangerous. As a result of patients needing support for the airway, for feeding tubes and wound healings that can be complicated, sometimes patients need to stay in hospital for a very long time. So all of these things make the experience and the recovery of such complicated surgery very, very demanding on patients. Head and neck cancer is the area that I work. It's the 6th most common cancer in the world. Certainly, the treatment of choice for head and neck cancer is surgery. When you compare that to something like blood cancer, like leukemia and lymphoma, which the treatment of choice is often non-surgery, like with chemotherapy and sometimes with radiotherapy. With head and neck, the treatment of choice, when you can, is surgery. So the surgery would involve removing the cancer, which you can see, and a margin of normal tissue, which usually is about 1 centimeter around what we can see as cancer, which is around the cancer and on the deep aspect of the cancer. So if you imagine such as a cancer on the tongue and having to add 1 centimeter around and below, it can cause a huge, big defect on the tongue, or maybe the gums, or maybe the cheek. And sometimes these defects can extend into the face, so you'll have a hole. And sometimes it extends downwards into the neck, which I showed you earlier on, and that can be a communication which would allow food and water to escape into the neck, which can cause a lot of problems because it's not natural for food to go into the neck around big blood vessels. So if we are able to reconstruct that, and we are able to provide a barrier between the mouth and the neck, patients are still left with lots of functional deficit because we've removed the tongue, we've removed the jaw, so they won't be able to speak normally, they won't be able to chew and swallow normally, which means they can swallow, but it's not going to be like normal. So all these changes, and also the fact that they are going to heal with facial scars and sometimes neck scars, these areas affect the functions that define us as human beings, the ability to speak and express ourselves, ability to move our face as part of an expression of our emotional response to the world, the way we present our face to the world, all of those things are significantly affected with this disease and the treatment. So the ability for us to go out and eat together, the ability of us to do fundamental things like pray, like speak to somebody else, these are all affected. These can be quite devastating because the quality of life is significantly impacted, not just functionally, but also emotionally, and how we think and how we feel and how we find ourselves in this world. As a result of that, people had a problem. So the problem is, how do we remove the cancer, clear the cancer, but yet try to maintain or give patients the best quality of life afterwards? So we know that collateral damage is one of the reasons why patients have all these problems. So if we can limit the amount of collateral damage, perhaps we can try to maintain or preserve a lot of the function and therefore quality of life. So the whole concept of minimally invasive surgery is a different way of doing surgery, which is by utilizing natural openings that we have in our bodies. For example, in the head and neck, we would have the nose. We have holes in the nose that we can, natural openings in the nose, in the mouth, for example, so we can get access to the areas that require the operation. But if we can't, could we make smaller incisions so that we don't have to cut through huge layers and huge amounts of tissue in order to get to what we need to do? And as a result of that, we hope that we cause less pain, lowered risk of infection because less tissue planes are opened, therefore less hospital stay, shorter hospital stay, quicker recovery, and reduced bone loss. So in the head and neck, we do a lot of minimally invasive surgery, as you can see in the picture. I've got the telescope, and the picture from the earlier video that I showed you is comes from using telescopes such as that. So you can see that it's a very flexible type of scope, but sometimes there are scopes which are bigger than that. They are more rigid, and they have to go into the nose or they go into the mouth. Sometimes we have the ability to also put some other instruments together with these scopes so that we can undertake procedures under the guidance of the imaging that we can see through the scopes that we put in. So you can see that I'm not actually looking what I'm doing at the patient side. I'm actually looking at the screen. So this is how it works with minimally invasive surgery. You look at screens. So as a result of this, which is a different concept from open surgery, there are problems with minimal endoscopic-based minimal access surgery because at the end of the day, the opening that you have compared to big openings that you make with incisions on the body, it's still very small, and therefore the field of vision is still very limited. And you can remember from my first video, you can see the shadows. Even though there's light, there's still some shadows in some corners of the view. The limited space also means that you can't put all the instruments that you need. And somebody has to hold the camera and while you hold your instruments because you only got two hands. So sometimes the person who holds the camera gets tired and then he moves and then you can't see, and then you have to readjust, and then it means time wasting, longer operation. And again, like I said, the light doesn't bend, so there will be shadows and you can't see past corners. And you can see that the flexible scope allowed me to pass through corners and navigate. But when you have a rigid scope like this person, the scope that this person's using, you can't do that. So that's a problem. Also, the images that you see on the screen, they are 2D. It's 2 dimensions, so you lose the third dimension, and usually you need that third dimension to be able to estimate how deep you are into the cavity, how close you are to the area of operation, and because you lose the depth, you also lose the ability to accurately know what your hand is doing based on what your eye is seeing, which we call the hand-to-eye coordination. And the skills that you learn as a surgeon with open surgery is immediate, the hand-to-eye coordination, because what you can see your hand moving, you can see the area of operating, it's all in the same area. The skill that you get by learning, repeating the surgery, doing the surgery, the skills that you get, those skills cannot be translated in the scenario of the endoscopic minimally invasive surgery. So people who want to do minimally invasive surgery, having done open surgery, will find that the training will be difficult because you still have to go through the learning curve in order for you to be able to acquire new hand-to-eye coordination with the endoscopic method. So as a result of the prolonged operation, prolonged training, sometimes people think it's more expensive. An operation can be done in 30 minutes. Why would you want to do an operation for an hour and a half? And patients might need to stay in hospital. So because of these costings, these are real problems that we face when we try to do minimally invasive surgery and not open surgery. So all these problems have actually been solved with robotic surgery. So robotic surgery, the technology that's been put into creating the system, allows us to actually do the same kind of surgery that we would do open, but without the collateral damage, because the robotic system allows us to overcome all, if not most, of the problems with which I described to you with minimally invasive surgery. So we can do the same surgery that we would normally do through the open approach, but done as easy and with as accurate as open surgery with the robot, but without the collateral damage. So here we have a solution to the problem. So I'd like to talk a little bit about how robots were developed, because you might be interested, because that's the whole purpose of this talk, which is to see how science, technology, engineering, and maths can help answer real-time questions. So whenever anybody asks me, what do I do? And I say, oh, yeah, I do a bit of robotic surgery. This is the first image that they see. This is Star Wars. That's how they imagine. They imagine this robot to be controls things by themselves. They can think on their own. They can do all the operation. But the reality is that it isn't. But we are heading that way. And this is what we say, life imitates arts, or art imitates life. Really in robotics in medicine started in the late 1980s. Robotics in itself first started in 1950s with industry robots, and in medicine it starts in the late 1980s. So there were two companies in America. One company is called Computer Motion, and they collaborated with NASA and gained funding because they imagined, like Star Wars, they wanted to create a robot that they could send out in space to undertake risky procedures to repair, shuttles and things like that. You don't want to send human beings there in case cables get damaged, and then human lives could be lost. So they tried to create that. On the other hand, the SRI Systems is a company that received National Institute of Health research grants in 1988 with the US Army. And the purpose of that grant was to try and create technology that could use to help evacuate soldiers who are injured on the battlefield without actually sending another human being. So I've often said that the competition between two companies on the same technology is not very good. So once upon a time, we might have grown up thinking that we have to beat our competitors so that we be number one and we can get all the grant and the rewards. But actually, in these day and age, collaboration is the new competition. So that's what they did. In 1995, they merged together to become one company called Intuitive Surgery, which produces, in 1997, the first couple of prototype robots that we use currently. One robot's called Lenny and the other robot's called Mona, because they decided to call the robot Da Vinci, Leonardo da Vinci. So Lenny is from Leonardo and Mona Lisa, obviously, So that's why the Da Vinci system is the system that's currently used most in the world, because it was the first robotic system that was introduced. So overall, there are about 5,000 robots in function. Obviously, the main users are in America, with more than 3,000 robots in place. Regarding robots in the head and neck area, it's also otherwise known as transoral, which means that the access is through the mouth, robotic surgery, or TORS. So after the FDA approval, which is the US government body that approves new medical devices and drugs, they went through what the robot was about and tested it, and they gave approval for its use for urology, cardiothoracics, and gynae surgery. And from 2001 onwards, almost a decade later, the FDA then allowed the robot to be used for head and neck transoral surgery. So in the UK, the first transoral robot surgery was done in 2011. And when I started in July, Royal Blackburn Hospital, I was appointed. About 6 months later, I took the first robot surgery in my hospital. So up till currently, that number's not right anymore. We've just got just under 100 cases of robotic surgery that we've done. So I'm going to talk about the robotic system. There are two robotic systems. Like I said, intuitive surgery is the most common. So that's one that we have in our hospital. So I'm going to be talking mainly about that. But just in case, for your own interest, there's another company that's come up with the Med Robotics Flex Robotic System. Before the COVID pandemic, this has been quite exciting because it's slightly different from the intuitive surgery system. Because of the multi-articulated camera system that they've got, which you can see that looks a bit like a snake over there. Unfortunately, because of the COVID pandemic, the company has gone into administration and probably bankrupt, I think. So it's a bit of a shame, but there are a few hospitals in the world that have got this system, and I think certainly in Australia, they are one of the leading places that actually have experience with this Med Robotic Flex robotic system. So the Da Vinci robotic system, people think the robot, they see the thing that's in the middle, which is actually one part of three parts that form the robotic system. So that part's called the patient side cart by definition, because it is the bit of the robot system that's next to the patient where it interfaces and undertakes the surgery. The more important part is probably the other two parts. We've got the surgeon's console, which is my super duper Xbox station that I get to play. It's very fun. I sit there and there are parts of the surgeon's console, which I will talk to you about later on, that allows me to control the robot. So the robot doesn't actually move without my control. And then we've got the third part, which is the vision cart, which contains the processing of the two systems, also contains the energy source for the cutting and coagulation that we use as part of the surgery. And also it's got where the camera processing is. And there's a screen at the top that you can see at the vision cart, and that allows the assistant next to the patient to be able to see in 2D what I can see in 3D at the surgeon's console, so they know what I'm actually doing and they can assist. So like I said, the relationship between the robot or the patient side cart and me, the surgeon, is a master and slave, which means that it can't move without me telling it to do. But we're not too far away now from the situation where with artificial intelligence, we can program the robot to undertake the procedure without needing the surgeon to be there in the same room. So the patient side cart is what I'm going to talk a little bit more in detail. So you can see that it's just like a car, you know, every year or every few years you get an upgrade. So there are three kind of circulating systems sidecar in currently. So the first one, which they produced after the prototype, is the SI, which is this model over here. And then that graduated into the X, and then we have the XI. These three models share a common feature, which is they have 4 robotic arms. One of the arm can be the camera arm. So we've got 1 camera arm and 3 instrument arm. So in the SI system, that you can see that definitely is the camera arm. You can't really put the camera anywhere else but that. But in the upgrades, you can see that they're all the same. So you can potentially have a little bit more flexibility in terms of where you put your camera and how you dock the robot next to the patient, which gives you flexibility in terms of access to the area that you need to work in. The most up-to-date system, which you might have seen in the montage, is actually this one. This is very, very different compared to what you've seen previously, because it's only got 1 single arm. So if you remember, it's got 3 parts here. So each arm will have its own hole, if you like, or incision that's made. So each arm will have its own entry port. So this system is called a multi-port system, whereas this one is called the SP single port, because if you need to make an incision into enter the body cavity, you would only need to make 1 incision to allow this single port into the body cavity, and through that you have all these 3 individual or 4 individual arms that would have had to have its own port in the previous system. So currently this SP is not available in Europe because we in Europe we haven't received the European certification for this medical device to be used in in the whole of Europe. So I have had a chance to use this during a conference I attended in Korea, and had a really nice play with this, and I'm looking forward to this when it comes to the UK. So like I said, you can see it's a single incision that's made into the body cavity, and it enters into that body cavity, and there's no other incisions that's made. So that's still an advancement to the previous. So if you look at the camera here, it's a 3D high definition camera. It's 3D because it's got the right eye and the left eye. So each camera that represents the eye takes its own data. So if you were to close one eye here, you can still see the field, but you get a 2D picture. So each eye images will then be on the vision card collated together so that you can get a 3D picture. The end of the camera is either 30 degrees or 0 degrees, which is flat. We choose sometimes to use the 30 degrees when the axis is slightly angulated and provides better view. So that's great for us. Here there are button functions that allow stroboscopy, which allows movement to be seen with stroboscopy. And then there's a firefly function, which allows imaging of blood vessels once we've injected a special dye into the system. So the instrument arms are called endowrists, and you can see that they come in various designs for different functions. So overall, there are two diameters, 5 millimeters and 8 millimeters. At the moment, the 5 millimeter is only available to be used on the SI system, and currently all the X's and the XIs use the 8 millimeters. So like, for example, here, we've got what we call the ProGrasper, which helps to hold tissues in place. This is a needle driver. This is what we call the Maryland forceps, and this is a vessel sealer harmonic, uses harmonics. Now, the endowrist is very, very clever. It can move in what we call the 7 degrees of freedom. So you can move it inside out, you can turn it, rotate it left and right. And then here at the wrist, you can also move it up and down, sideways, this way. So if you put all of this together, it actually works in such a way where it allows the range of movements, which is more than what your normal wrist can do. So if you were to do surgery, with your normal wrists, there are certain movements that you cannot do, but it will, with the robot, allows you to do that and can overcome some of the difficulties in certain tight areas, corners inside a very constricted cavity, like, for example, a tube, like where I work in the head and neck. So we've talked about the patient side cart. Now we're just going to move on to my Xbox surgeon's console. So I sit over here. It's very ergonomic. So when I sit, I set up my surgeon's console so that it fits my short size, small size. So I can, so once I've set it up, it's saved into the system. So next time I come, I just press my name button. It's got my name on it, and then the machine just moves automatically to my best position. So here is where I interface with the robotic system, which is the finger clutch system. So I put my thumb and my fingers in here. There's a clutch at the top, which we call the clutch button, which allows me to move this arms, I suppose, so that it sometimes during surgery, because you don't really realize, sometimes your hands end up over here and it's a bit difficult. So you press the finger clutch so that you can move the hands without actually moving that in the robot. So it's quite cool. So you've got foot pedals. So the left foot is controlling the camera. You can move the camera inside out. You can also focus the camera to make the camera vision better. The foot pedals on the right side control the instrument arm on the right and left. So this is instrument arm on the right, instrument arm on the left, and the yellow is usually cutting energy, and then the blue is coagulation energy. So so you've got a small video which can show you how good the computer system is. It has a program which allows what we call tremor reduction. So if you have tremor in your own hands, it's not translated onto the other side. So it also has micro movements, which means that you can move, I'll just show you that video again. So you can move very small movements in your fingers, but big movements over here to get what you need to do in the area of the operation. Okay, so this is the view that you can see. The camera is, what you see is 2D, but in fact, you can see how detailed, high definition it is when I see through the vision visor. So this is the tonsil, this is the tongue base, this is the tube that goes down into the lungs to control the breathing when the patient's asleep. This is the back of the tongue, and the area of operation is here. So you feel it's magnified 20 times. You feel like you're taken into somebody's back of the throat when you're doing the operation. Okay, that's the visor, and that's the view that you can see through those eyepieces. When I put my head over here, there's a speaker which allows my voice, which can be quite soft, and I'm tucked away in the corner of the room and far away from the patient. So there's a speaker that allows next to on the robot itself, so that my assistant can actually hear what I'm saying, so that he can assist me. Sometimes some hospitals, they have the speaker attached to big speakers inside the room, so everybody can hear, not just my robot assistant. So you can also have conversations with your anaesthetist or any other parts of the team inside the theaters while you're operating without having to move from your console. Here is a video of the setup. I will take you through it. So this is the old robot. This is the first robot that we had, which is the SI system. You can see that the scrub nurse has got several trolleys of instruments, which contain the instruments that I used, the endoris, the camera, and the retractor. So you can see that the middle arm here is the camera arm. We've got the two instrument arm, and the fourth arm is tucked away at the back. This is where the instruments are docked with the cord. We also drape the patient on the robotic arm, because we have to maintain our investment of £1.5 million, which is how much we paid for the robot. So the patient's brought in by the anaesthetist. You can see that the eye is well protected. He's got a tube that allows him to breathe during the operation through the mouth. So very limited space. So I need to make sure that the tongue is out of the way and preparing the patient so that we can then put the retractor in place that holds the mouth open and stable throughout the procedure. So this is the process of moving the robot into position, which is harder than side parking, I can tell you that. So this whole process needs to make sure that the foot of the robot's properly aligned to the bed of the patient. So I'm having a chat with my assistant about what we're going to do. So he's put the instruments into through the mouth. We can see that he's got a screen over there. He can see what I need to do. I'm now just kind of moving the instruments a bit, just to have a feel of the area before doing the operation. And my robot assistant, he's got the harder job because he has to see a 2D picture whilst operating, and then also making sure that his head is out of the way, because sometimes the movement of the robotic arms that I make, I can't see his head, so sometimes it's possible I might knock him unconscious if it's too hard. So you can see I'm having a chat with him, and we're just talking about what we need to do in order to remove it. Okay. So now I am going to show you what the robot can do and how the robot has made a difference in head and neck. So I think this is where I need to warn you about images, which I'm going to show because they are clinical images. So oropharyngeal cancers are cancers that occur behind the oral cavity. So the area of the throat, which is behind the oral cavity, is the oropharynx. So the oropharynx here involves the tonsil. So you can't really see this, but this is an abnormal tonsil. We can only see this once we've pulled the tongue out of the way. There are lots of shadows. And in order for us to get to this cancer, the way we would normally need to do that would be to be able to see this area properly, because I need to remove a centimeter around this tonsil. So again, this is the warning. So the way we would get to that tonsil would be to make a cut on the patient's face along the lines which I've marked. So we have to cut the area above, just below the lip, around the chin and into the neck. Okay, so once we've done that, we've cut down straight down to the bone. And then in order for us to get the tonsil, because the tonsil's all the way inside, we would have to cut the bone so that we can then pull the bone. So this bit of bone here is now lifted up to the ceiling. And this bit of bone here is lifted to the opposite side, to the right-hand side. And the skin in the neck here, this is all pulled to the outer side so that you can then see the tonsil, which is marked in that yellow. So you can see the amount of aggressiveness of this disease, of this approach, which we call the lip split mandibulotomy approach, in order to get to a tonsil cancer. We haven't actually removed the tonsil yet. We've just done open access surgery in order to get to the bit of tissue. So once we've removed this tonsil, what we will get is we will get a hole from here inside all the way down, which would allow food, saliva, and everything to go down into the neck, where I've shown you before, where the blood vessels are. So this is significantly invasive for the patient. So with robotic surgery, instead of having to do all of this, we just open the mouth and we put the instruments in the right place, and we will do the same surgery that I would have to do with this old surgery, but using the robot and without doing everything that I've shown you. So just to orientate you, this is the soft palate. This is the tonsil that you can see. This is the tongue. So I'm seeing this from the roof of the mouth, looking down, looking back. This is the right-hand side. This is the left-hand side. So I'm making an incision. As you can see, the energy that we use, electric energy or electrocautery, allows me to make the incision without spilling very much blood at all. You can't, there's hardly any bleeding here. This is very, very good, because if you don't have bleeding, it means that you can see your tissue planes better. You can identify where you're going, so that you don't cause any extra damage or accidental damage. Okay, there's a little bit of bleeding there. That's all right. We can stop the bleeding. My assistant is moving the other instrument. So I'm just opening up the tissues, and I'm looking for the next layer, because we need to get to the next layer in order for us to find the correct layer for the operation, which we call the parapharyngeal fat spaces. And it's very important to be able to see this area properly during the operation, because in the middle of the parapharyngeal fat is where you would find the internal carotid artery, which is one of the major arteries that provide blood supply to the brain. So we don't want to injure that artery during this operation. So the yellow piece of tissue that you can see over here is the parapharyngeal fat. But in order for me to get that, I need to make sure that I control this bleeding. So my assistant will help put these metal bits, which we call surgical clips, at the artery and blood vessels, veins, so that they don't bleed during the surgery. So over here, I know there are lots of blood vessels, so I have to be very patient and very careful in my dissection so that I don't accidentally cut into them. So I'm now kind of doing what we call blunt dissection, and there you can see the blood vessel. The view that the 3D camera gives you in high definition allows you to see this, especially magnified. These tiny blood vessels are about 1 millimeter to 1.5 millimeter in diameter, so they are quite small, but you can see how big they are magnified with the robotic camera. So I know there are more blood vessels, so I'm just cutting the area very, very carefully, and just making sure that my assistant has put the clips in properly, because if these clips come out, then you will have flooding of blood, which is not good, as you can see. So now that I'm very, very happy with that, I'm just going to go downwards from the top of the tonsil down to the base of the tonsil. So you can see here, this is where the tonsil is, and I'm trying to put a centimeter of normal tissue around the tonsil so that I have given a good healthy margin of normal tissue to make sure that we don't leave anything behind. Now, knowing from my anatomy, which I've learned in my preclinical days, there's going to be another blood vessel somewhere around here. So I'm just going through this area quite carefully, and now you can see the blood vessel just over there. Okay, now that I'm fully satisfied that I have got everything that I need on the side of the tonsil, now I need to make sure that I've got everything that I need in terms of the margin on the other side of the tonsil, while making sure that I try not to overcut. Because if you overcut, it means that you're not preserving natural tissue as much as possible. So it's a fine balance of making sure you don't overcut, at the same time you're making sure that you don't leave any cancer behind. So because of the camera of this robotic system as well, you can see the quality of the tissue that you're cutting, and that helps you determine as well whether or not you are cutting through healthy tissue that's required as part of margin, or and making sure that you don't leave any cancer behind. So now that I've detached the top corner of the tonsil, now that helps me reflect better to see the deep side of the tonsil, to make sure that I've not left anything behind. And what I've noticed is that probably I need to cut a bit more muscle layer to take with the specimen, so that it ensures that I'm in the right plane, that I haven't actually cut through the cancer. So you can see that the parapharyngeal fat layer there is now much clearer. So now that I'm happy with the depth of the cancer resection, I'm just going downwards towards, on the other side of the tonsil, down to the inferior pole, which is the most inferior part of the tonsil, which we've established earlier on the outer side. So the deep part of the tonsil here as well is critical, because also from anatomy, I know that there's muscle here. There's a muscle down here in the base of the tonsil, which we call the stylopharyngeus muscle. Behind the stylopharyngeus muscle is the internal carotid artery. So in order for me to make sure that I don't accidentally damage that artery, I need to find that muscle. So we will find that muscle at the end. So now you can see I've joined up both sides at the inferior margin of the tonsil, which means that I can now see the specimen from below. So, okay, so now I can see the stylopharyngeus muscle, which is this. And now I'm just going underneath and behind it to make sure that there is no vessel underneath. We get the clip in place, just in case. And then we cut through that. And we've removed the cancer completely, as you can see, just checking the back of the cancer, and the cancer is removed. So this whole procedure only took me 30 minutes. I didn't have to split the lip. I didn't have to split the jaw. I didn't have to damage any of those structures. Only took 30 minutes. So something like this means that the patient is going to be able to expect to eat and drink normally within 48 hours of the procedure, whereas the previous procedure with the lip split mandibulotomy access, patients will not be able to eat for at least 2 weeks, and to make sure that the tissues at the back have reduced in terms of swelling and has healed enough that it doesn't cause any leak if they start to eat and drink. So that's the huge difference that the robot can make. I now will show you another case. This patient was referred to me because she snored. So the reason why she snores is because you can see on the scan, the sagittal cut of this MRI scan shows this high enhancing lesion in the posterior wall of the pharynx, which is the back of the throat. It's growing forward and touching the tip end of the soft palate and closing the airway, because here is the airway over here. So when the patient sleeps, the tongue will flop backwards Okay, I think I need to go faster. Here you can see how close the vessel, the internal carotid artery, is to this vessel over here. So we're going to try and remove this with the robot. So again, to warn you, it's going to be a bit difficult. So this is the swelling, and this is the, which you can see that was protruding. So I want you to focus on this area here, because once the video starts going, you can see pulsation over here, which is the internal carotid artery, how close it is to the surgery. So we're making a cut on the mucosal surface so that we can then expose the lump. You can see how the surgery can be done precisely, and it's very nice, clean dissection of the lump over there. So here you can see the pulsation and the artery being very, very close. But because of the no reduction in tremor, magnification, I'm quite confident that I can remove this without injuring the artery. And you can see the artery is so close to it and so obvious. And you know that there isn't going to be any accidental tremor from your hand that could injure the vessel. So this lump from the scan showed that there were lots of blood vessels, so we were expecting this to be bleeding a little bit more than normal. It's coming out in small parts, but the robotic equipment allows you to stop the bleeding effectively while doing the procedure. You can see it's cauterizing, and once we've controlled all the bleeding, we can make sure it's removed everything, which we have. We've now put this hemostatic sheet into and now the wound, and now we are going to close the wound. So you can see how the robotic system allows you such control in very restricted spaces, and allows you to do very fine work predictably and safely. And knowing that the artery is there, you can still confidently know that you will not injure the patient. So that's the amazing kind of endo-wrist equipment that very clever engineers have created, and to allow people like me, surgeons, to have fun in theater without much stress, and it's great. Okay, I'm not going to talk about this because you don't have time, but you understand what the robot can do. So I'll just briefly tell you about this case. So this patient had a submandibular gland problem. This is the gland. It's a U-shaped gland. Half of it sits inside the mouth, half of it sits inside the neck. So the traditional way we would do this would be to make a cut, as you can see, which is marked over here, through the skin into the neck, so that we can then remove the gland. So there are problems with this because obviously this is going to heal with a scar. It's in an area that's quite exposed. If it's a woman, you're going to have a scar in your neck, which is going to be quite unsightly. Over here, there is a nerve which comes out and allows you to smile. And that nerve can be potentially damaged as a result of accessing this gland from outside. Also, there is another nerve on the inside, which is close to the inside part of the gland, which is called the lingual nerve, which allows you to feel your tongue. So that nerve can also be damaged as a result of the surgery. But because we have an equipment such as the robot, and it allows us to think outside the box with a little bit more innovation, I've developed a technique where instead of taking this gland from outside, we make an incision inside the mouth using the robot and all the advantages that the robot can give me to remove this gland from inside the mouth. So the patient doesn't have any scars on the outside, and the patient doesn't have any risk of having any paralysis of the face following the procedure to remove this gland. So I'm not going to show this to you, but this is the way that we would do it with the robot. And finally, on the same idea of thinking outside the box, and I think this is really important because when we are young, we are told that things have to be done this way within this box. So you have to do your exams, you have to go, if you want to do medicine, you have to do this, you have to do that, and your path is within that box. But sometimes in life, you have to think differently, slightly different and think outside the box, because particularly because if the solutions that are currently present within the box doesn't solve the problem. So you have to consider other options, and you have to think outside the box, other ways of doing things. So the robot gives us the opportunity to do so. So I will show you this final case, which I did together in America with my fellowship director, Josh Lubeck. This is a patient. This is the scan. So the scan shows the bone. So the bone normally would have a white outline like this, because the whiteness represents the calcium, which you have tons in the bone that makes it strong. So when you see that the outline is not white, like in this case here, then it tells you that the calcium and the quality of the bone is compromised. So what this patient has is osteonecrosis, which is bone death. And the bone death here is caused by the bone being radiated, because the patient previously had a tonsil cancer, and he had that treated with radiotherapy and not the robot. So radiotherapy can then give you this complication. So this complication means that the bits of bone that's not alive anymore has become infected, because you know the mouth is full of bacteria. So bacteria like to eat bad and dead things. So it caused him a lot of problems. So the only way we could deal with this problem is to have to remove this dead piece of bone, which is what we can see over here. So the plan was to remove this jawbone from here to here, and we can't leave the man like that, because if you don't have a jaw, how can you speak? You know, you don't have a lip, you don't have a chin, your tongue will collapse. So we would have to rebuild that jaw. So part of the skills that we learn in my training is reconstructive surgery, and we learn the same kind of methods that people do organ transplant, which we call microsurgery and free flap reconstruction, is what we would do in this situation. So we use CAD/CAM to plan where we're going to make the cuts, and the software allows us to customize cutting guides where we know where, so we attach this cutting guide specifically to the arrangement and the shape of the bone, and from there we know we need to make a cut over here, and we need to make a cut over here. So using the same software, the CAD/CAM, we also chose to take the fibular bone, which is the extra small bone in your leg. So the bone that allows you to walk and support your body is called the tibia, which is the shin bone. You know, if you accidentally bang your leg and it's really, really painful because it hit the bone. So that bone is the tibia, but we're not using that bone because obviously you need that to walk and to support yourself. So the fibula is perfect for reconstructing the jaw because it's a straight bone, and it's got its own blood supply, which you can see over here, which we call the peroneal artery. So in order for us to take this bone and to reconstruct this large piece of area here, we would need to take the bone and the blood vessel with it so that we can then reattach this blood vessel and this bone in the new area. So the planning also allows us to cut these two triangles out from this straight piece of bone so that we can then move this segment inwards and this segment inwards, so that what we get at the end is like a U-shape piece of bone that would fit in with the normal structure of his jaw. So that's the plan. The problem is with this man is not the jaw so much, but the problem is the blood vessel. So the blood vessels in the neck, when we do surgery, we tie them off, so you can't use those blood vessels anymore. And when the blood vessels are also radiated, because they are in the radiation field, they also undergo scarring. So the blood vessels that are immediately in the area which we normally use to reattach the blood vessel from the fibula cannot be used. So that is a big problem. So where can we find a suitable artery that can be a donor artery for us to reattach to the peroneal artery that will come with the fibular bone? So thinking out of the box. So there's no vessel in the neck. So where's the next area that's closest? So there are blood vessels in the chest behind your breastbone called the internal mammary artery. So IMA, internal mammary artery. So what we did was, together with the cardiothoracic surgeon, we used the robot to try and find the artery in the chest and to bring the artery up into the neck so that we have a donor artery, which we attached the peroneal artery. So as you can see, it's been restitched here using very fine sutures with under the microscope. So the other blood vessel, which is the vein, which we need to reattach as well, we've borrowed from the arm. So from the arm down here, we've taken that vein and turned it up into the neck so that we could reattach. So you can see the bone in place, and we've got titanium plates, which we customize in order to fit in with the shape of the fibula, which we've planned. So this is the middle section, and then this is the bit where the triangle's been removed. And you can see that the blood vessel, the peroneal artery, is attached to the internal mammary artery, which has come from the chest into the neck. And here is the cephalic artery, which we've cephalic vein, which we've taken from the arm, attached to the peroneal vein. So this is how the jaw looks like. So we've taken a bit of skin with the fibular bone, and some of the muscle on the fibular bone has been left exposed. We've stitched it to the mucosa inside the mouth. This is immediately at the end of surgery. This is the gentleman 3 months later. You can see how amazing it is for him. He's got a chin. He looks normal. His face is symmetrical. The area here, the skin and the muscle has fully mucosalized and looks normal, like a normal mucosa. And on the CT scan, you can see that the shape of the bone is exactly how we had planned it to be, where the middle section and the two lateral sections are attached together. And if you think that's amazing, look at this picture. 2 years later, we were able to build on top of the fibular bone that we have taken by putting dental implants with a superstructure on top of the dental implant that supports his denture that he wears. So in terms of that, that is the reason why I do what I do, because at the end of the day, you can cut out cancer, not a problem, but it's what happens to patients after the diagnosis and treatment of cancer, and giving them the ability to regain some normality and quality of life is the biggest reward that you can get in the job that I do. Okay, so I'm not going to talk about this, but this is really just to show you this slide, the problems that we've had with the old robotic system. Because of this bend over here, we can't really get access to this area. So that's why something like a single port with multi-articulated instrument arms and the camera will allow us to actually do the operation in tight corners like that. So this video you might have seen, I don't need to show you, but it shows how this camera in a tight field like this can go forward and do the operation when previously the rigid instruments aren't able to. Okay, so finally, I said patients is the center of everything, and I work very closely with the patient, head and neck patient support group. They come, patients who've had cancer in the past, they form a group. They call themselves the Swallows, and they provide supportive care for newly diagnosed patients or patients after treatment who need, support in different ways, how to go through the journey. And I'm just going to play this video because these are my robot patients who generally contributed their time to talk about their experience with the robot. And you can get this.
They sorted out and you'll be back to normal. So I was full of confidence virtually straight away.
There wasn't any better option than using the robot. It was important to get back to work as soon as possible, more from a financial point of view.
The recovery time for me was quite fast. I was in hospital 4 days. It wasn't horrendous at all. It wasn't bad. It was just an operation like anybody else has.
Oh yeah, definitely. Yeah. I mean, I would recommend it 100%. Yeah. It's less intrusive. You can recover a lot quicker. Well, it saves your life at the end of the day.
I would definitely say have it done without hesitation.
If it hadn't been for the robot, I don't think I'd be here today.
Nowadays, cancer is very treatable. People live a long life after the diagnosis and treatment of cancer.
At this time.
Okay, and you can see some collection of photos of my patients and me. So in the middle here, he's my first robotic patient, and he was part of the video. I see him. He's now 5 years cancer-free, back to building, going back on his holidays. He's having. Is not back to normal. My patient, I took his fibular bone to reconstruct, and we've gone cycling together 170 miles to collect money for the Swallows charity group. And this is my patient who insisted that I should take a photo with her on the ward because she was able to swallow the next day. And you can see she said that was the best cup of tea that she's had ever in her whole life. And finally, this is my other robot patient who, together with me, we ran the last 2 miles of her 160, no, she did 60 miles in September to collect money for cancer research. So it's very rewarding. The robot makes a huge difference in patients' lives, and it's really important piece of equipment that I was able to use because many people from different areas of expertise have come together and built something as amazing as that, so that I can then do the work that impacts on other people's lives in a positive way. So these are some of the pictures that show some of the work that we do in our hospital to teach people how to use the robot. My teaching activities, this is my registrar. We have a simulator at the end of the surgeon's console over here that you can turn on, just like the Xbox. So he's sitting here, he's doing these curriculum that teaches him how to control the robot, have understanding of how to coordinate your hands and foot and eyes. He also gets a chance, once he's done that, he has to get 90% in all of the exercises. And he gets a chance to, drive the robot in the right position, prepare the patient for the surgery. And then he sat at the robot's console over here, and I'm panicking over here because I'm trying to teach him how to do it and to make sure that he does it well. So it's a really nice atmosphere. The other team it's all about team, because I need the right team around me in order for me to be able to do the work that I do with the robot. So we often have days where we come together and we learn, and we allow people to have a play with assisting, have a play with docking the robot and stuff like that. So apart from that, we are trying to develop ways where we can improve the technology to make it cheaper. So this console here is a trainee surgeon. He can see what I can see because he's been attached to the console, but the console is £500,000, and just for that purpose, it's just too much money to spend. So we are trying to develop ways where we can get the output data from the 3D camera, so that we can use something as cheap as Google Box here. By putting the phone over here, we can stream the surgery that we do, so that our registrars will not need to sit over here, but they can then just wear these things and witness the surgery. So this is what you can see on the right eye and on the left eye, and both of this merge together to become a 3D picture that you can see through this VR. We've done a few textbooks during COVID because the procedure is in aerosol generating and high risk area, because that's where the COVID virus sits. We've created a cheap way of a closed chamber to allow the procedure to be done using an existing drape, which is the same drape that we use to drape the robot, but we use to drape the patient and create airtight holes and heavy suction to prevent spread of the procedure of viral particles, and for the procedure to be carried out during the COVID times. We also participate in other research which relates to the robot in cancer, and I'm very pleased to say that our team has been awarded Team of the Year by our hospital this year. And like I said, it's such a pleasure to be working with my team. We have lots of fun in theatre. It's not really work, and I'm not going to be here without them, and especially my robot assistant Joe, whom I wouldn't really work with anybody else apart from him, because he's next to the patient and I trust him. So in conclusion, robot-assisted surgery has changed the way we surgeons approach head and neck cancer in particular. We can't use it for all patients. We have to choose the right patients so that they can maximize the benefit that the robot gives them. But the robot gives us opportunities to think outside the box of innovative ways to try and deliver high quality care in terms of outcomes for the patient. And I'd like to thank Intuitive Surgery rep Yannick Lowe for supporting me during my time. And we often go to Europe together to attend surgeries with other robotic surgeons and education activities. Thank you very much indeed. I'm sorry I've overrun. I'm happy to take questions.
Okay. All right. Doctor, I think I represent everybody when I say wow. That's all I can say. Wow, indeed. So we're gonna go for short Q&A session, and lots of questions here tonight, Doctor. And I think we're gonna choose this one from Maisara. She wants to ask, the advancement of robotic surgery, does it affect job opportunities for fellow surgeons? Do you think the robots will make, human hands obsolete? What do you think, Doctor?
The answer to that at the moment is obviously no, because as I mentioned, the robot and surgeons, robots are slaves. We are the masters in a way. So robots can't move without surgeons. So you can have the robot sit in the corner collecting dust, but you still need the surgeon to move it. Essentially, the robot is a very fantastic tool. Like any tool, you need somebody to move the tool, get the most out of the tool, so that you can get the outcome that you want. So maybe one day we might come to a point where with AI, with navigation technology, with scans and things like that, and 3G, we can be in a position where we don't need surgeons in the room and the robots can do it on their own. But the question is, do patients want that? Because there are discussions ongoing about whether or not patients find the idea of robots automatically doing the surgery, because at the end of the day, surgery is about trust. You will only allow somebody to do something to you that can be because if it's not a surgeon and patient scenario, if I took a knife and made a cut on you, that's assault. I can go to jail for assaulting somebody. But that doesn't apply in this situation, because there's a consent process, and the surgeon undertakes the procedure with the consent of the patient, and the aims of the procedure and the risks of complications are discussed fully, and verbally as well as in written form. Then you get consent, and then you go ahead. So with the robot, you're not going to have a consent, and because the robot will not be able to explain in detail. And finally, complications have to be managed. So you can only undertake surgery if you can manage the complication. If you can't manage the complication, you cannot undertake surgery, because that's not how it works.
I see. And there's another question about complications. How would you handle mistakes while you're operating the robot? There's another question. I can't pinpoint where, because there's a lot of questions there, but I remember one of the students tonight asked about that. How would you handle such a situation where you made a mistake with the robot?
So mistakes can happen. We're all human beings. One of the biggest risks of robotic system is obviously bleeding. So if it bleeds, we have to stop it. So depends on what kind of bleeding. If the bleeding is small, we cauterize it, as you can see in the videos I showed you how to do that. But sometimes the bleeding can be quite profuse, and in order for you to stop the bleeding with the cautery, you need to be able to see. But if it bleeds very, very quickly, it's like a flood and it fills and you can't see. So in that situation, you would have to apply pressure. So we have steps that we undertake. Sometimes, although I've never experienced it before, you can get bleeding, significant bleeding that doesn't work with whatever you've tried. So in that situation, you would have to make a cut on the neck, find the blood vessel that supplies the area, and then ligate that, and that usually stops the bleeding. Sometimes we often, as part of the team brief, because we always have a team brief before the surgery starts, and we discuss everything about the patient, what we're going to do, whether we have the right equipment, is the robot charged up or not, and things like that. And
It's a checklist, yeah?
Yeah, as a matter of routine, we also talk about potential emergencies. So one of the emergencies that can potentially happen in the area that I work is fire in the airway. Because the gas that the anaesthetist will put in order to put the patient to sleep, they're highly flammable. And
I see.
and then there's also going to be oxygen, because we all need oxygen to survive. So oxygen is highly combustible. And of course, I use electric when I make my cuts, and you can see the
that's
smoke
true.
and everything. So it can happen. It's never happened to me before, but we train for it. We go through the like a mock of what happens. Okay, so when there's a fire in the airway, somebody's going to shout 10,000 feet, because that's our code word for emergency, and then he's going to say fire in the airway, and then we can remove all the robotic instruments within, and the robot completely out of the way within 12 seconds. It's very, very quick, because we practice. So in that time, there'll be another person who is like the scrub nurse next to my assistant. He will get a jug of water ready and pour water into the airway. The anaesthetist, when my assistant shouts fire in the airway, will cut off the oxygen, so prevent further. So those things we practice during times when like I showed you, we have education sessions, so we go through the whole thing, so it becomes automatic. So those are the usual two complications. The other thing that can happen at the time of surgery is you start the surgery off, and in the middle of the surgery you realize that maybe the cancer has grown much, much bigger and very, very quickly in the space between the scan that you did before, which you planned your surgery on, and then the time of surgery, the cancer's grown bigger. So if the cancer's grown too big, then you can't do it with robotic surgery. You would have to abandon robotic surgery, and you would have to do the lip split, which I showed. So those things can happen. I mean, it's never happened to me before. It's one of those things that can happen, and we often talk about it as a team. And part of the consent procedure as well with patients involve, if the situation requires us to do a lip split mandibulotomy, we may need a lip split mandibulotomy. But often it's not that urgent, and sometimes what we do is we just abandon the procedure, and then we wake the patient up and rediscuss again. So
you're prepared for all contingencies, basically. It's like a fireman or an air steward. You're always prepared for contingencies.
We have plan A, B, C, and D. So
yeah, and thinking outside the box. All right, Doctor, we have a student from KMP who is prepared to ask you a question in person.
Okay.
So I'm going to invite him in. Yusuf, you are in. Hello,
Hi.
Yusuf. Assalamualaikum.
Hi.
Hi.
All right, Yusuf. I'm gonna leave you with the doctor, and you can ask her your question. Yeah.
Yeah. Sure. This is an honor. My name is Yusuf, and I am from Metropolitan Police. My question is, will the robotic surgery one day be applied to every single type of surgery there is? And yeah, that's it.
Thank you for your question. It's a very good question. Actually, I had a slide which I didn't include today, but the slide shows the proportion of surgery that's undertaken in a hospital by the different surgical specialties within the hospital. So if you were to look into that slide, slide will show you that urology surgery, which is surgery relates to the kidneys and the bladder, the prostate and things like that. They are the main users of the robotic system. So in my hospital, again, and that's reflected in not just my hospital, but all the hospitals in the world. General surgery also use it. So things like bowel procedures that would have been done laparoscopically can sometimes be done with the robot. Gynecological surgery, which is surgery relating to kind of the uterus, the ovaries, and things like that, they're also usually done laparoscopically. Can also be done with the robot. So compared, and also cardiothoracics, which you saw some bits of it is being explained. But so head and neck TORS is probably one of the smaller specialties that use the robot, but even though we are much smaller users, the impact on our patients is huge, as you can see.
All right, Yusuf, how was that?
Yeah, that's what I
All right,
expected.
Yusuf.
Yeah,
Thank you very much for your question. Thank you very much. Appreciate it, Yusuf. Thank you. All right, doctor, that was a great first session. And I know you talked a lot, you shared a lot, and we learned a lot. We're going to have a short break. We're going to show the video montage again. So in the meantime, please drink water, go to the toilet or whatnot. We're going to have a conversation for the second part of the program. Okay. So
Okay.
video montage, here we go.
Thank you.
All right, we are back. Welcome again to Saving Lives with Robots with our guest of honor, Dr. Naseem Ghazali. So we have talked about extensively, we've talked about your experience in the robotic surgery field and the amazing things that robots can do. And now we're interested in talking more about you personally, doctor, like your life experiences, your life journey. I understand that you have a slide prepared for us for that as well. So we
Okay,
can
so
put it up.
let's.
This part will be more of a conversation. So we're going to see how Dr. Naseem Ghazali got to where she is now. So I'm sure students have lots of questions in mind about how did she do it, where did she start, what kind of education journey it will be. So we'll answer that in this session. In the meantime, please continue asking your questions, sharing your thoughts about tonight's event in the comment section. We will keep an eye on the comment section as always, and we will pick questions at random when we have the time at the end of the session. So,
okay, so life is a journey, and we all have our own journeys, and really that journey is towards finding our own special place in this world. You cannot be anybody else but yourself, and you have a unique contribution that you can make to this world, and that's why you are in this world. So it's really important that you realize this so that you don't compare yourself with other people, because comparing yourself to another person is the thief of joy, they say. So find your own joy, find your life, and you will find that special road ahead of you. So my journey has been slightly my own personal road. I am a consultant maxillofacial surgeon. In medicine, there are two types of people. One we call medics, who are physicians who treat people by prescribing medication, undertaking minor undertaking things like being an anesthetist or a pediatrician and something like that. But there are also another group of people who use surgery to treat conditions, and they are called surgeons. So I'm a surgeon, and In terms of surgical specialties, which we mentioned earlier on, there are 9 recognized surgical specialties by the Royal College of Surgeons in the UK, one of which is the oral and maxillofacial surgery that I'm part of. So oral maxillofacial surgery is quite unique because it requires surgeons to be doubly qualified in dentistry and medicine. In order for us to be able to go into the higher surgical training in the area. And in Europe and in America, it's considered to be a double qualified expertise. It is a bridge between medicine and dentistry, and the area that we work in relates to the mouth and the jaw, the face, and the neck. So within the big area of oral and maxillofacial surgery, there are a few subspecialties. Head and neck cancer, which removes the cancer inside the mouth and its subsequent reconstruction, including microvascular free transfer, which I mentioned earlier on. There's also a section of us MaxFac surgeons who do craniofacial deformity, which is correcting congenital defects. For example, you were born with a cleft, or you were born with a misshapen face. Facial disfigurement, that can be also the result of other things. So you correct that facial disfigurement, hopefully to restore the quality of life as a result of it. And then the kind of general oral and maxillofacial, which relates to surgery with the teeth, including implants, the jaw joint, saliva glands, which produce saliva in your mouth, and also the skin on the face. We also have a bit of interaction with medics in general, or physicians, through the branch called oral medicine. So there are some conditions that affect the rest of the body that have symptoms inside the mouth. For example, certain skin conditions, certain autoimmune conditions, certain bowel conditions have problems inside the mouth. And so we often see these patients with those symptoms in our clinic. We also deal with a lot of emergency work that relates to trauma, either by accidents, fights, and gunshot wounds and things like that. And finally, we also do cosmetic surgery as a result of the fact that we deal with conditions in the face. So here are some kind of examples just to show you facial trauma, broken jaws, cleft surgery with babies, for example, facial deformity. So people who are born with the mid-face being slightly far back in relation to the rest of the face, we can do surgery to enhance that by moving, making the cuts and moving it in the position that makes the facial appear more harmonious overall. I'll show you some bits of reconstruction where we use CAD-CAM to reconstruct. We also reconstruct soft tissues and flaps. Here's the mouth cancer scenario.
Yourself, doctor?
Pardon me?
The CAD-CAM picture here, do you do the programming yourself using the software?
Yeah, some of us do that, but because we have so much other things to do, so what I do is I dial in with a biomedical engineer who works with a company that produces the customized devices.
The collaboration you mentioned before, yeah?
Exactly, collaboration. So these biomedical engineers are experts in manipulating the software. But of course, they don't know how to do the surgery and where to make the cuts. So by having a discussion with them like we are right now, for example. So my biomedical engineers, they live in Amsterdam. So, we set a time and we do it online. And the scans from the patients are uploaded onto the system, and we share the screen, and we have a conversation about where we need to make the cuts, how much angulation we need. So they manipulate the software. So it's quite
cool.
It's very cool. It's very, very nice.
International too.
Yes. So I know that some people in Malaysia are actually doing this as well. So for not just for this, but for placements of dental implants, which is this area here where we place these titanium screws into the jaw. So they can do the same thing. They can plan the placement of this using CAD-CAM. And I know that in Malaysia they have it as well already. So that's interesting. We also do dental surgery, like I said, take teeth out, wisdom teeth. Sometimes there's other surgeries to do inside the mouth, little bits of bumps and lumps and bumps that we remove out. facial skin cancer. So obviously in the same way, we would remove this with a margin of normal tissue, and we would borrow skin around the area to reconstruct that. There are also benign conditions that cause growth in the jaw, sometimes cysts, and they cause facial deformity and problems. As you can see, it's expanded. So we would, deal with that as well as part of our specialty. Here is a gland called the parotid gland, which produces some saliva inside the mouth, and you can see that there's a problem there. And we in this case, it's a cancerous growth, but sometimes you can form stones inside the system and block the flow of saliva. So we would sometimes use telescopes or endoscopes to try and remove that. So that's part of our work. And again, this is jaw joint surgery. This is where the jaw joint is. It's in front of your ear. So when you open and close your mouth, you can feel that bit of your jaw moving. That's your jaw joint. Sometimes there are problems with joints like any other joints in the body, and sometimes we need to do arthroscopy into a scope inside, wash the joint out. Sometimes we have to remove the joint and replace it with a joint replacement, just like in hips and knees, where people older people with degenerative disease.
Arthritis, right?
Yeah, that's part of our work. And again, cosmetic surgery, we all know what's that. So head and neck cancers, different types of cancers in the mouth, oral cavity, which I showed you earlier on, oropharyngeal cancers, the tonsils, facial skin cancers, saliva gland cancers, and complicated non-cancerous jaw conditions like those big ones that I've showed you. So that's the area that I subspecialize in. And of course, reconstruction, which involves flaps, which means tissues that we transfer from another part of the body to where the defect is, which is inside the mouth. You can have pedicle flaps where you don't detach the blood vessels, you simply rotate them into the position while retaining the blood vessel in its place. And sometimes you have to detach the blood vessels and transfer the whole thing and then reattach them in the neck, which is which I showed you earlier on, which is vascularized flap and microvascular surgery. Also, patients with paralyzed faces, the nerve, we graft the nerve, we transfer the nerve from the other side and graft it so that you can then have movement of both sides of the face, and that's called facial reanimation, which is part of reconstructive microvascular. So that's quite cool. So I have a case here which I can show you. So this patient had big cancer over there, and it's exploding out to the face. So we have to remove all of this tissue here, along with continuously with over that. So I'm sorry, it's going to be some horrible pictures coming up. So I warn you. So this is how it looks like. We've cut the jaw here, and then we've cut the jaw on the other side. You can see the main blood vessels in the neck, which are all exposed. The tongue is brought down because all of this here is basically all the cancer that we've removed. So this is the cancer which we removed. That's the section of the lip. That is a titanium plate which was previously there that treated an old kind of disease. We've removed the cancer, which you can see over there, along with the jaw. Is the section of the jaw on this side, another section of the jaw on this side. This is the floor of mouth. And then that's the neck, because we had to remove the glands in the neck as well. So this is looking from outside. So that's the lip. That's the bit that was pointing out. This is the neck section, and that's the jaw. So we borrowed the tissue at the back from the back, which we call latissimus dorsi, which is this big, huge muscle over here, and took a little bit of the bone, which is the scapular bone underneath here. You can just about see the outline of the scapula. And this is the artery called the thoracodorsal artery that supplies this whole area over here along with the bone. So that's what we've done. So we've taken the piece of tissue, and the artery is just over there leading up to there. You can see just kind of the outline. So we're using a microscope and very fine instruments and sutures which are narrower than your hair. This is what we would do. We would stitch this. This is what I can see under the microscope. And you can see that, we are just stitching the blood vessels together.
That's very fine.
Yeah, very, very fine. You can only see this under the microscope. So if we drop that needle in the operating field, we can't really see it because it's so fine. We would have.
Is that real time or sped up?
No, this is sped up.
Okay, I mean it's impressive if you can do that fast.
Yeah, so the one side is done, so we do the other side.
Wow.
This only takes about 30 to 40 minutes to do. sometimes. So this kind of skill actually helps us with the robot as well, because you do this indirectly in a way. So it's almost done. It's coming up now. Okay, we then release it, and you can see the blood supply being reconstituted over there. So this is the donor vessel, and it's going up into the flap. So for the veins, this is what we use. This is a special equipment. So so this is the vein. So the vein is pulled up into this device with spikes on one side and another spike on the other side, and then we bring the two spikes together into the plastic disc, and then we kind of smash it together so that it joins up. And then we remove the instrument that helps us to bring that together. So now we're just checking to make sure that it's secure. So once it's secure, we will then release the clamps on either side, and you can see the blood supply following the reattachment of the blood vessel. Can you see? So that's what.
Whoa. So
as a result, the flap gains its arterial supply and drains blood through the veins. So
Doctor?
So that results in that reconstruction. So that tissue here is pink, just like the patient's face, because the blood supply has been reconstituted.
Which part of the body that you can borrow to put in this section is a specific part of the body? You can't just borrow whatever tissue, right?
You can't just borrow whatever tissue. I think the idea is we would like to replace like for like. So for example, if there is bone missing, we would want to find bone. If there is skin missing, we would want to find skin. So if we had both, we would want to find what we call an osteocutaneous bone and skin flap. Sometimes we only need just skin. Sometimes we only just need bulk. So we try to put muscle. And then it depends on the patient's blood supplies. For example, in the leg, we can only use the fibula if the blood supply to the fibula is intact. So you have to have three special, there's a special pattern that the blood vessel needs to have. So we sometimes kind of plan by doing additional scans like angiogram, where we make sure we put a contrast, like a dye, into the blood vessel, and then we check that the pattern of the blood vessel is suitable. Sometimes people have broken their bones, for example, can't use that side. Sometimes they are right-handed, so we have to use the left hand. So things like that come into consideration. But generally speaking, we tend to find the tissue that's missing and reconstruct like for like.
I see. Interesting. Thinking outside the box. Wow.
Yeah. So the other thing that I like to do in my job that I get the opportunity to do is research and innovation. So innovation, something like surgical innovation with the robotic surgery. That's quite cool. But there are also other things which are very interesting. So if you're somebody who's curious and you're somebody who likes to find better solutions, then research is a good area for you to go and exercise your curiosity. So clinical trials are the safest way that we can introduce new methods, new drugs, for example, to improve treatment. So currently with the robot, I'm involved in one clinical trial with the robot. So we're comparing robot surgery versus conventional treatment with radiation and chemotherapy, and also by trying to reduce the amount of radiotherapy and chemotherapy that you can give for such a patient. So it's quite a cool trial, because if the trial shows that the robot surgery works just as well, then it's a game-changing. Because at the moment, robotic surgery is not considered gold standard for certain types of treatment. And being part of these trials actually help to make changes in the way that we do things.
How far along are you in the trials? If you can share with us, how far along?
How long? So
how far along?
How far along? So I help to recruit patients to the trial because I'm a robotic surgeon. So there are not many robotic surgeons. So by enrolling patients into the trial, with any clinical trial, there is a target number that you need to recruit, so that the result that you get at the end is statistically significant, which means that
yes.
it's
you need math.
yeah, it's valuable in terms of its efficacy, and you can prove it with numbers. So
Right. Yes.
yeah, so it's and sometimes people don't want to be involved in clinical trials, but fortunately all my patients are very keen, and I think that my patients sometimes are a selective bunch. They like the idea of having robotic surgery because they want the latest technology, and it's not uncommon because certainly in America people are asking, younger people especially are asking for the technology, even for simple things like removing tonsils, which is a standard procedure that can be done using standard processes. But people know about the robot and they ask for it because it's the latest technology. But so it's one of those things, and part of the biomedical department. And with the biomedical department, I work with biomedical engineers. We try to develop new devices that can sometimes detect. So we're working on something that can detect viruses at the back of the throat. So it'll be quite useful for COVID, for example, but also in my particular situation with head and neck cancer, because some cancers that I treat with the robot are caused by a virus. So these viruses are what we call oncogenic viruses, which are viruses that can cause cancer. So if we remove the cancer that was caused by a virus, we remove the cancer, but we haven't removed the virus. So if the virus remains, and the cancer can recur. So that means that the treatment might be affected because we haven't eradicated the cause of the cancer. So by working closely with biomedical engineers, we can help towards the holistic treatment of patients rather than just treating what we can obviously see is the cancer.
Wow,
So
this is STEM in action. This is cool.
exactly.
So cool.
This is why this is quite nice to actually, speak with all of you, because I think that sometimes, in the culture, we think, oh, it's a doctor or it's an engineer, is a doctor is much more important than somebody who works in kind of engineering, or we sometimes even like science. But actually, we can't really do the great things to help patients if we don't have the help of engineers. And that's why I mean by life is a journey for you to find your place, for you to have your unique contribution to human and mankind. So this is my bit that I do, but I can't do the thing that I do if other people don't do the bits that they do, that they should
Amazing.
do.
Amazing.
So in my job, I'm also expected to educate. I train my junior surgeons in the field of oral maxillofacial surgery. I'm also a senior lecturer with the School of Medicine and Dentistry, so I get students who come in and observe and sometimes participate in undertaking things like special study modules, which like a little project that they can help us along with auditing and things like that. So in Malaysia, I'm a visiting professor with the Faculty of Dentistry, UM, in the area of oral maxillofacial surgery, and I've got some photos which show some of the fun things that I do with Malaysians. It's really nice to be able to contribute back to society. As I said, collaboration is the new competition, and we become more by sharing. We don't lose anything by sharing.
I agree. Yep.
And sometimes people think, oh, if I help somebody, then they'll take my opportunity. But actually, by helping others, you are helping yourself become richer. And I would encourage that. So I also work with other surgeons in Asia, like in Cambodia. So, like for example, here is we did a masterclass on oral cancer, and it was quite nice to be able to work with the team. And some of these students here eventually came to visit me in the UK as part of their attachment program in their masters. So here I came another time to teach about flaps, and you can see I'm showing the aesthetic subunits in order, because we need to understand this in order for us to be able to reconstruct. And later in the week we had this. I participated in this thing called a silent mentor program. So a silent mentor program is when people donate their bodies to medical science, so they become our silent teachers, because we learn from them through their bodies, which they've kindly donated to us. So in UM, this program runs, so the medical students actually interview these patients before they die, and just to get an understanding of who these people are, so that when we actually come down to the activity of learning to do the surgery on the patient's body, we we respect their contribution, and we are grateful for their generosity in sharing their bodies with us. So so these are the bodies, and these are other students. We are paying our respects to them, and before we start, and here we are, the Silent Mentor, a banner in the background. Here we are, having had the lectures, we now come to consolidate our knowledge, and some diagrams that we show, and so that I know they know, and they know that they know what they're going to do. So so some diagrams about flaps, and just showing, and people telling me what they were going to do, how the landmarks are, and eventually actually doing the work with the students. And then this is showing how, how somebody ran into some problems, and, just kind of discussing. And at the end, we had a group photo. This was not the serious one. This was the smiley one. But before that, we had a serious one. And some of these people you might recognize from this picture over here, because they came to visit me in the UK. You can see the robot in the background. And some of them in the pictures are my trainees that I train as part of my role as a medical educator. And of course, I always tell them a healthy body is a healthy mind is important. So I insisted that they come up with me up the hill to see this important landmark in the area that I live. It's called Darwin Tower. And as you can see, they're not used to climbing up hills, but they're so happy that they made it. And, we had to take a photo just to kind of show that.
During the cold, because they're wearing like a thick jacket.
Yeah,
there.
it was, I think it was April. So it was late spring before summer. So it still can be a bit cold, and it can get windy at the top.
Yeah, and they have to beat the weather too.
Yeah, so this is the view from the top, and it's just a metaphor for people who are climbing hills, climbing challenges in their lives. When you get to the top, you will see that it's worth all your effort. And you will see that you have silently, when you're witnessing this, silently appreciating the feeling that you get within you, a sense of achievement and a sense of completeness at the top. And of course, we all have to make sure we eat after that. So it was quite nice to be able to kind of sit down and have a meal. And it's all about building relationships. It's all about enriching yourselves by interacting together and understanding people as human beings, so that when you come down to actually doing the work, there's already a dynamic there that you can build on and achieve bigger things. As I went to Cambodia, the Max Facts department over there, we did a little bit of teaching as well. Again, collaboration is the new competition. And, you can see how, how difficult the difficulties that they experience, and you share your knowledge. And at the same time, I also learned many things. I saw different types of diseases that I wouldn't have seen in the UK, or maybe even in Malaysia, that they get over there, and they present challenges, and we are able to operate together, and you can see how close we work together. And that's one of the nice things about working in surgery. It's the close collaboration as a team. It's nice to be appreciated. At the end of the day. So how did I end up the way I did? Obviously, this is my primary school. I was in KL. My family lived in KL, but my father received a scholarship to go and do masters. And for 2 years in my life, I spent in America, in California. And it was quite interesting because I learned different things over there. The schooling system was different. People were more encouraged students to be self-directed, and I found that to be something that fitted my personality, because I don't like people telling me what to do, I think. So having your own motivation and going for the things that you like, I think I really did enjoy that very much indeed. And of course, around that time was when Star Wars Episode 4 came out. So all the day I can remember just playing Star Wars all the time, and to be able to use
those were the days.
yeah, it's crazy, but it's my
Elementary
formative.
school is like sekolah rendah here in Malaysia, right?
Yes, that's right. So after elementary school, you go into high school, I think. So it's slightly different. We didn't have to wear uniforms, and so that was very nice. But of course, you come back, and I came back to the old school, and I learned that I had to do well in my exams, because exams in Malaysia, unfortunately, are the only way that people value you as a student. In fact, it was quite sad, because in America they valued your education differently. But of course, you
How
have to get
so?
on. Pardon me.
How so? Because you mentioned something interesting. So in America, they value you differently. So how different?
I think it's they place less emphasis on academic results.
I see.
And there's a lot of emphasis on other things. But of course, if you want to go into um, professional courses, I guess, if you call medicine as one of them, then it becomes highly competitive. And then of course, then your grades are everything, the SAT scores particularly. So but in the young age group, in the primary elementary school level, there was hardly any exams at all. It was all about play. It was all about learning through play, and exploring your personality in terms of creativity. And
Wow.
so it was a big, it left a big mark for me in my life. Of course, we have to do exams to get into secondary school, and I was really lucky. I did get the grades, and I was offered a place in College Tunggal Kusha, which is a big place in my life. I learned important things in life, which is like friendship. Friendship is everything, and the things that you go through with your friends, and your friends will be with you for life, apart from your
Yeah.
family. Friendship is a big thing. And if it's not through this friendship, I would not be here today, because Madam Azila is one of my friends in this school. And we, after how many years, 20 years, our friendship still remains.
Wow.
But also, while in college, I got a chance to experience different things, which helps me form this outlook of thinking outside the box. So, for example, I was a science student, but I was also an art student, and I took art in my SPM. So you can be a scientist as well as an artist, and it requires two different minds, ways of thinking and looking. Perception is everything. How you look at things, and also. I was in the band, and I played music, and also that kind of allows you to think differently, appreciate things differently. There's a certain discipline that goes into being part of a marching band. You have to look after your instruments, teaches you a little bit about self-mastery, and also I was involved in kind of drama, and sometimes drama means that in order for you to be an actor, you need to kind of understand what it's like to be another human being. And all these things are important, because they put you in good stead as you grow older, into whatever profession, whatever career that you wish to do. It doesn't have to be career, but also just any relationship with people, family, children. It's a formative year for me. And then I went to Asasi Science, and then into Faculty of Dentistry. So again, this period of my life was a big turning point, because this is the same time where all the matriculation students are at the moment. If you asked me, I didn't want to be a doctor. My heart was set on being an architect. That's what I wanted to. But I think when you're at this age, the influence of your peers, the influence of your parents, their expectations of where you should be and what you should do come into play. and you feel kind of torn in a way, what you should do. Should you follow your heart? Should you follow the expectation? And sometimes what you need is not someone to tell you what to do, but someone to kind of open your mind and show you different things so that ultimately you can make up your mind. And I hope that, my lecture today is one of those things that allow people to see things differently and maybe dream about different things, because I haven't done things the conventional way. In Asasi Science, I was in science, obviously, and the expectation was that I made a deal with my dad, which was I would do the Asasi Science and I would do it for 2 years. And if I got into medicine and if I liked it, I would go ahead. And if I don't like it, then I'd done my bit and I would like to go and do architecture, if that's okay. So that was the deal with my dad. And,
That's a good deal.
it was a good deal. I think he probably manipulated that a little bit. But anyway, I did that. And while I was in Asasi Science, I did study in the first year, but while I was there, I discovered different things. I discovered politics. I discovered wider things that impacted on the community and life. And I got involved in student politics, and I didn't study so much. It wasn't that interesting anymore. And unfortunately, my exam results reflected that, and I didn't get into medicine. I didn't get into science. In fact, I didn't get to medicine or dentistry. I got into science. And in they have such a system where if you got very good grades, but if you were offered science, you could go into fast track science. So instead of doing 3 years, you would do 2 years. But my grades weren't that good. I wasn't even in fast track science. And it was quite a challenging time for me because my parents were very, very upset.
Wow. Yeah, I can imagine.
Yes. And, in fact, my dad kicked me out of the house. So I had to figure out.
Seriously?
Yeah, seriously. So I had to figure out what to do because he was really upset. And he said to me that if I thought I knew what I wanted to do in life, then maybe I should figure this out so that I can,
How old were you?
So I think I must have been 18, maybe something like that, 19. So very interesting times. Then that's where your friends come. So your friendships, the friendships that you make, the people that you went through difficult times together. I just had the clothes on my back and a bag, and I went to stay with my friends. My mom had arranged to meet with me outside the house because I was not allowed, and so she gave me a little bit of money. So I had about 5 to 10 ringgit or something like that. So, but my friends, they came to help me, and they put me up, stayed there, had a roof over my head. And when we went to to register, I still remembered everybody had to have like X-rays and underwent medical examination as part of registration. But I didn't have any of that because I didn't have any money. So I had to queue in this special row where people with no money or didn't have a chance to do medical had to kind of queue. So I learned some really hard lessons. And a week later, I came down with chicken pox, and so I was off from school. And then I came back, and then somebody said, your name's up on the dean's office. And I'm like, okay, I got into trouble with student politics again, so I better go in. So it turns out that my name has been pulled up to go into dental school because somebody pull out from medical school, and because they didn't want to do medicine, and so there was a space, and somebody in dentistry wanted to do medicine, so they went up to do medicine. So that created a space for me. So I became a dental student.
By chance?
By chance. It was by design. I think that's just sometimes, the doors open for you if you were meant to go through that door. So I became a dental student, faculty of dentistry. And it was in this time. Actually, I don't like being a dentist because I think there were certain things about dentistry that didn't suit me, and I didn't really enjoy my first 2 years because it was all heavily dentistry subjects. But in the third year of dentistry, we came across this subject called oral surgery. And for the first time in my life, I found something that I really liked. Okay, it's not architecture, but this is oral surgery. And there was also another subject called general medicine and general surgery for dentists, because we deal with patients. So we need to understand how medical conditions, tablets, medicines that they're on can impact upon our practice of dentistry. And also we take some teeth out under general anesthetics. So we need to make sure that the patients are fit for the general anesthetic and therefore fit for surgery. So we have to, learn this subject. So the subject was taught by medics and surgeons for the whole year in third year. But in the third year, we also learned oral surgery, and I really enjoyed it so much. I just kept going to the library and kept reading and finding more books to read. And when I found this book, this is like the standard textbook for oral surgery, written by Killian Kay. And if you open the book, you'll see that the authors have got medical qualification. And for the first time in my life, I was really amazed, because I thought, wow, they're doubly qualified in dentistry and medicine. And then I discovered from some of the tutors that have come back from the UK that in the UK, oral and maxillofacial surgery is a specialty of medicine. And if you wanted to do it, you'd have to be doubly qualified in dentistry and medicine. And also the scope of practice that oral and maxillofacial surgeons do here in the UK is much, much bigger and wider and more, and involves more challenging things like oral cancer, not just removing the cancer, but also reconstructing it, managing the airway, managing the patient from start to end. Whereas in Malaysia at the time, and certainly still currently in some places in Malaysia, you would have to combine the surgery with maybe ENT. And if you are an oral and maxillofacial surgeon, you can't admit the patients under your name. You can't fill in death certificates. So I felt that all these things limited the scope of practice that I wanted to do, which was oral cancer. And it was through oral surgery, when I did my oral surgery attachment in year 3 of dentistry, that I met and saw patients who were chewing betel quid, or what we call sirih pinang, which causes cancers. And, and I saw all these things, and I saw the impact, and I said, this is what I want to do. And that started my journey to where I am today.
You found your calling.
I did. And then
in a subject during dentistry, which you originally hate.
Yes. So
wow.
I think the lesson in that is sometimes the things that you hate, you will find the things that you love. So don't run away from things that are difficult and things that you hate, because actually there is something in there that you will find you love, and you will be grateful for that. So that's the lesson that I took in my dentistry years. And in my dentistry years, I was really lucky because I got the Royal Scholarship, which is quite a prestigious scholarship. Only 8 people in the country in a year will get it. And somehow out of the blue, I was offered the scholarship, which means that I didn't have to be on a JPA scholarship during my dentistry. And I wasn't expected to work for the government after qualifying like most people did. So so that allowed me to follow the plan that I had charted out for my life. And I wanted to be doubly qualified maxillofacial surgeon in the country, and there wasn't any in Malaysia at the time. I would be one of the first few people to do that. And in order to do that, I needed to get training in either the UK or America or somewhere else. So I spent a lot of time in the first 2 years of following my qualification of dentistry to think about where I want to go and get my training and how I should go about doing that. So so after dentistry, I went straight into private practice. I helped to set up with my friend who his first dental practice, and in that time I was able to study for my exam, which is the Royal College exam, the fellowship of the Royal Fellowship on Dental Surgery, Royal College of Surgeons. So it's the qualification as FDS RCS. And if I had that, then I could get into a shortened medical course. So instead of doing my medical course in 5 years, I can do it in 3 years. So it was really important for me to get the FDS. So I focused on that, and I was able to pass the exam first time round, the written paper, which allowed me to get onto the next stage, which was to get the clinical 12 months compulsory clinical attachment in a recognized center by the Royal College, so that I can sit for the final FDS. So so it was, you know, a lot of things doing, but in that time I met lots of people who helped me. People from the Ministry of Health, Dr. Sharifa Fauzia, for example. There was the previous dean of the dental school, Dr. Arifin. He was also the head of the dental services in the country at one point. And, you know, they offered a lot of support and a lot of opportunities for discussion. Dr. Zainal, Associate Professor Dato now, he's full professor, was the former dean of He's also one of my big mentors, and he's like a big brother to me. And I enjoyed his experience. I valued his opinion and you know, advice, and you know, all these people. And finally, I was able to come to the UK to do my final part, and so I passed both parts first go, which is quite unusual at a very young age.
Wow.
Yeah, at a very young age, and I was able to attend the Eastman Dental Institute. And there is a picture of Malcolm Harris. He's also one of the old professors. I think all Malaysians who are max fac surgeons will know Malcolm Harris because of his close relationship with Malaysians students, especially surgeons. So I was here at the Eastman. I was offered to do a master's. I would have done it in 3 years, but because I passed my fellowship, it was shortened and condensed into 1 year. So in that year, I did that, and I applied to go into medical school, and I was offered a medical school slot in Guy's and St. Thomas's. So I joined in Eastman in September of 1997. Yeah, and then I was offered a place in medical school in February 1998. So it meant that between September 97 to September 98, I was doing 2 courses. I was doing a master's as well as an undergraduate course in medicine. So it was really very, very challenging because for many reasons. So for example, like one reason was because that was the time where there was a huge financial crash. So because of the huge financial crash, all students overseas, who were on scholarship, the scholarships got suspended. So I was in the UK, and I got a place to do medicine, but my scholarship was suspended, and I couldn't go ahead to do it. And I was really devastated because it was so difficult. And I managed to get a place in, you know, medical school, and the fees were really expensive. We were talking about, you know, £10,000 at the time per year, and you know, I didn't have any money to support myself.
Wow, what did you do?
So I found people that gave me some odd jobs to do in the Eastman where I was there. I helped other people. They paid me to do some, you know, run some of the research experiments. I spent a lot of time there to do that. And then I made friends with the guy at the corner shop selling kebab. And every night he would see me at the end of his shop, and he would give me free food. It was really you know, very, very humbling, you know, experience.
Dr. Naseem,
yeah.
if I may ask you, because this story that you shared, it's amazing because you started off at a path that you don't want. You didn't want to become a dentist, and then you weren't a good student. I mean, your father kicked you out, and then once you found your calling in oral surgery, suddenly you have all this trajectory in your academics. I mean, you got into the fellowship, first go, and then you got into the scholarship and everything. I was just wondering, what's your drive? really? I mean, why oral surgery, and why does this drive give you this energy, you would say, to go all out, to being like one of the few people with this certification?
I think I have often asked myself what is my motivation, and I think one of the things that motivate me is complexity and things that have intensity. I think I like complicated things. I
I
like
see.
to things are not simple, and I like the complexity of the subject, because the anatomy is difficult. There are many ramifications. You have to think. Uh, it's a lot of thinking, and at the same time, it allows you to do a lot of work with your hands. I think I've always enjoyed doing things with my hands. I was one of the reasons why I liked art, and I wanted to be an architect, because an architect, sees things three-dimensional, and you
Hmm.
kind of solve human problems by your designs. So it's not hugely different.
In that
Being a
sense, yeah,
surgeon,
it's not different.
yes,
Yeah.
not hugely different. There's a lot of kind of technical aspects to it that can challenge you. But the other thing as well the work that I do, is a lot of intensity there, because you are dealing with
Hmm.
a life and death situation.
Yes, definitely.
And the other thing as well is, sometimes the other secret thing about it is that I think I don't really know myself.
Oh
So I
wow,
don't think,
interesting.
yeah. So here's the thing. So you think you know yourself, and then suddenly something surprises you, and you discover a different aspect of yourself. And and I think that the journey of life takes you to yourself, um, because you then become more aware of who you are, what
Hmm.
you are, and why you are the way you are. And the more you know yourself, the more you can be who you are meant to be, and therefore you can then contribute um, to the world by being who you are. And I think one of the things about head and neck cancer is you are helping somebody in the time where it's a life and death situation. If you didn't help them, they will die. And
Yeah.
you see how they are when people are like that, when the gun is faced in the barrel of the gun is in your face, and you know that you're going to die. And if you don't do something, and helping people in this situation allows you to see your own humanity, and how you are the same as them, because one day you are going to die too.
Hmm.
And it's a privilege. I know it's a word that's used so often. People say it's a privilege to be able to work with patients and help them, but it is really a privilege to be able to um, help patients in that situation, and also to be part of their journey, because it's a very personal journey. And if you weren't their surgeon, you weren't their doctor, you would not be able to, you wouldn't be in that bubble, the closeness, the trust that people put in your hand. These things are very precious, and you don't experience that any other way. And in doing that, in being with them in their journey, and in seeing your own humanity, you learn something about yourself as well.
Hmm.
And for me, that's really the intensity of it. The emotional intensity of it. You cannot disregard your own humanity, even though
Yeah.
people say, you can be quite robotic about things, right? You know, you,
I mean, we
which
are talking about robots, how,
yes,
but
we
the
are.
humanity of it, it's quite ironic. It's quite
Yes,
ironic, but
it
I
is.
can sense your passion and love, not just for the job you do, but also for the patients you've helped. And I'm sad to say that we don't have more time to dig deeper into your story, but the end part of it is quite significant, in that you don't have a traditional, you'd say, journey into being a doctor. I mean, you wanted to be an architect in the beginning, but then you found your calling by design, you say, in one of the subjects that you found hard in a hard program. So I'm just going to give a chance to one of the students that we have tonight to give you a question. I'm just going to search for a lucky person who will be the last question of the night, and then I'm going to leave the floor to you, Dr. Naseem, to give us final say to the students, the future doctors maybe, who are listening tonight. So this one in particular, speaking of you liking difficult situations, one student want to ask you, Humaira, what's the hardest surgery you've done? You've done, I'm sure, hundreds of surgeries so far. Is there any one in particular that is seared into your mind?
Yeah, there's lots of difficult surgeries. They are difficult by different ways. They are difficult because they are technically difficult. They are difficult because they are emotionally difficult. So, for example, in a situation where it's technically difficult, we had to remove cancer in a lady, and we then decided to use the hip bone with the muscle from the abdomen, which we call the deep circumflex iliac artery, DCIA flap. It's a complicated flap in order to kind of rebuild her jaw. And then we did the procedure, and then the artery anastomosis, which were when we reattached the vessels together, it didn't work. We had to take everything down. We had to do it again, repeat it again. The surgery took 23 hours.
Oh, wow.
And it was physically demanding, mentally exhausting, and just technically challenging as well. So that was really hard. But it's not something that I would want to do again.
Definitely, yes.
Yeah, but it was difficult. But fortunately, I trained in America when I did my fellowship. In America, we would start the day. I would wake up at 5 o'clock in the morning. I would go to the gym for about 45 minutes. And then by 6 o'clock, I'm in the hospital. We're doing a ward round. And we start our cases around 8 o'clock or 8:30. And we operate until whenever we need to stop. And sometimes operation can finish at 11 o'clock. Sometimes operation can finish 12 o'clock. Sometimes can finish 2 o'clock. Sometimes 3 o'clock. And when it finishes around 3 o'clock or 4 o'clock, I just don't bother going back to my apartment. I'll just crash in the sofa in the department. So, we do surgeries like that at least every other day, if not every day, something like that. So, you become accustomed to it. But it's you train, and leading up to moments where you are the main responsible operator, and you find that your training has prepared you for it. But there are some things that training doesn't prepare you for, and you experience it because it happens. And those can be quite emotionally challenging. For example, we operated on this man, and he had mouth cancer. It was very removable, what we call very resectable, and therefore curative. But he had a very dodgy heart. His heart was, he'd had bypass surgery, and it was touch and go in terms of whether or not his heart would hold up for the procedure that we were going to do for him. In the middle of the operation, his heart stopped. His heart stopped. So whatever situation you're in, if the heart stops, you need to do CPR.
Chest compressions, yeah.
That's right, chest compressions, oxygenation, and things like that. So the worst bit was I was tasked to do the reconstruction bit. So we decided to take his rectus abdominis muscle, which is the six-pack muscle that people have. So we took one side of that with the blood vessel, and we wanted to use that to reconstruct his tongue, which we removed as part of the cancer operation. So I was in the process of trying to close the defect in the abdomen, which we've already taken the flap. So I need to then close the abdominal wound. and that was when he had the heart attack.
Stopped. Oh, wow.
So there's a hole in his abdomen, and I have to jump on the operating theater and start compression on the operating theater. And you can see that every time you compress the chest, the abdomen will respond because it's, interconnected. And, we had to do it so many times, but unfortunately he didn't make it.
Oh, wow.
And in the end, we had to stop the compression, and he passed away, unfortunately, and we had to close the wound as well. So it was, emotionally devastating. And the hardest conversation to have with the family. And then you also have to make sure that your team are doing okay, because there are junior doctors who work with you, and you need to look after them as well, because it's traumatic. If you have felt that it was emotionally difficult, they would have found it even harder, because they were junior doctors. They don't necessarily want to be doing cancer surgery. They might want to be doing, they did that job because they needed an orthodontic job, or they needed something non-surgical. So so those are really difficult moments.
I can't imagine. Wow.
Yes, you should have you don't know how much you have inside you until you kind of experience it in that situation.
Wow. Goes to show you that if you don't have the passion for it or the heart for it, it may not be the path for you, but luckily you do, Doctor. So Dr. Naseem, is there any last words you would like to leave our students tonight? Any parting words that you want them to remember from your talk tonight?
So I think, first of all, I've said, know yourself, and it's really important that you know yourself. And it's about the process, engaging in self-discovery, understanding who you are, why you feel the way you do, and should you feel that way, is there a better way of doing things? Because old people, the ancients, they have realized that self-understanding or knowing yourself is the greatest wisdom in life. And the way to do that would be to look inside first before you engage with the outside world. Because if you don't look inside and you try to engage outside, it's so easy to blame other people, other things, circumstances for things that happen to you. And it's natural because it's easy. We like easy things. Even though I like hard things, but most of the time people like easy things. So the way you would do it would be to ask yourself, what do I feel? Because sometimes your body will tell you how you feel, and your thoughts will try to override things sometimes. And it's important to recognize how you feel, because it's feeling that drives us, our motivations and our actions. And therefore, it's really important to understand how you feel. Why do you feel that way? Is it because you see things in a particular way? Is that the right way to see something? Because perception is key towards how we live our life. If we see the world as a dangerous place, then our actions are going to represent that. We don't trust people. We don't want to work with them. We hide things. We wouldn't put ourselves out there because it's dangerous, and therefore, but by doing that, you limit yourself. You create such scenarios which can sometimes be more difficult for you. So that's why perception is everything. And if we change our perception, tell the story differently, we might be able to change ourselves and how we do things. So if life is difficult, if your dad kicks you out from the house, you have no money, it's okay. It's freedom. That's another way of looking at it. You're freed to do what you want to do without any restrictions. But if you feel like somebody kicked you and you're not loved anymore, then you're going to look at life differently, and you will not be able to face the challenges that you need to. So perception is key. Because perception is key, and it enables you to kind of change how you do things and how you manage yourself in facing difficulties in life. That's what we call self-mastery. In order to be useful to the world, you need to be the master of your own ship, of your life. So that's the first stage. Second stage, once you know who you are, what you feel, where your boundaries are, what you'd like to do, what you don't like people to take advantage of you, where that boundary lies, how much of yourself you can give, and how much you should care for yourself, then you can then develop teamwork, because then you can have open communication with people. You are freer to collaborate, and you have clear skills to communicate, because you know what you need to say. You can say it clearly because you know what it is that you need to say and where the boundaries are. And following that, you cultivate a growth mindset where you constantly look inside yourself. You think you know yourself. Do you really know yourself? Why do you feel that way? There are certain things that we're not perfect human beings. We have our imperfections and kind of like things that can be improved, like it's easier to kind of ignore those things because and disown them because it's not part of us, and therefore we don't need to do anything about it. It's always the other person's problem. But actually, if the more we embrace those things, the more we learn to be self-compassionate. And in order to be compassionate to other people, the first compassion is towards yourself. So in order for you to be able to grow, you need to be able to have that. And the cycle then carries on. So this is what I mean about cultivating good habits, and try to do that as soon as you can. Get yourself a mentor. Surround yourself with people who can give you advice. We don't need someone to tell us what to do and where to go, but sometimes offering pointers, and we can then decide ourselves where we want to go. Sometimes we need someone to pick us up because we've beaten ourselves up so much because we made a mistake, for example. And people to remind us that, mistakes are just like small setbacks for you to launch you into more success in the future. And sometimes they hold a mirror in our face, so that we confront areas where we've quite easily tricked ourselves into thinking that we don't need that work to be done. But you want people to hold these mirrors up to you. My principle is always healthy body, healthy mind. Make sure you get yourself moving, because moving yourself is one way of knowing and grounding yourself in your body. You are a living thing, and that living thing is your heart, and you are encased in this body, and you need to look after this body so that this body can take you to do the things that you want to do. So look after it. Be physical. Go and do physical activity. Physical activity also makes you feel better about yourself and about things that happen to you, because sometimes challenging times, anxiety, for example, difficulty, sadness, if you go out for a walk or you go out and do something vigorous, like I'm going to go out cycling in a minute, it helps to manage some of your feelings, and it helps you tire yourself out so you get a good night's sleep, because sleep is important, because you need to process what happened in the day during your sleep so that you incorporate those things into yourself, so that you can then move forward and be in a better place to achieve more. Again, like I mentioned briefly just now, setting boundaries, personal boundaries is important. Sometimes if you say yes so many times because you want to please people, because you feel that it's expected of you, and then you sacrifice yourself. You don't get enough sleep. You don't get enough support in doing what you need to do. And sometimes saying no is good, and knowing how to say no and knowing when to say no is really, really important. It's part of self-care. This lesson I only learned, very recently in the last 5 years, being a consultant. You want to help people so much, you say yes all the time, and then you realize, you get run down to the ground, and you then are not able to provide people the best version of yourself. So it's really important to understand about personal boundaries, and within that boundary is all about self-care. Always important to have a gratitude, a feeling of gratitude, and for everything that you have, even though it's difficult, you can still find something that you can be grateful for in life. Even the fact that you can swallow okay, which we take for granted, but I know that some of my patients' greatest wish is to be able to swallow a normal piece of food, but they can't. Show kindness to people, make time for people, because you give something of yourself which you don't know how far that will take you. So, for example, like today's, it's one of those moments where you hope that what you say can change people's lives, that they can then change other people's lives, and it's like a chain reaction that's positive. And have generosity, because we have forgotten how to be humans. We've become so selfish. It's all about individuals, and forget about the community. And and I think that's really important. And you will gain more by being generous. And that's my message. Thank you so much for your time.
I hope everybody is clapping together with me. Wow, thank you very much, Doctor. It was very, very meaningful, especially towards the end when you share with us your inspiration, your passion. And hopefully it translates, even though virtually, all over from the UK here to Malaysia. And I hope the students here really get the heart that you put into your presentation. Before we end, as a moderator for tonight, I have to do some last minute housekeeping stuff. We have our quiz winners. If you don't realize, there's a quiz that's happening for KMP students. I just want to announce the winners here tonight. These are the names. Wait, why are we still here? All right, there you go. These are the names. So we will contact you guys. Congratulations for winning. And thank you, Doctor, for spending your time with us. It was 2 hours and 40 minutes of pure gold. And I hope it inspires future generations of surgeons, architects, artists, whoever it might be. As long as you put your heart into it, you're going to do great. Thank you very much, Doctor. That's all for tonight. That's all from me. My name is Aiman Azlan. And we will have this last thing. It's like a tiny cute thing that we prepared for you, Doctor. If you can see, we have this certificate giving ceremony. It's virtual. It's quite cute.
Okay.
You can see it. I'm going to show it here. There you go. So yeah, if we can't give it to you physically, but hopefully one of your robots can take it on your behalf. So thank you very much, Doctor. I hope you enjoyed it as much as we do. Thank you everyone else for joining us until the very end. That's all from us. Thank you. Assalamu alaikum. Have a good night. And for you, Doctor, have a good day. Bye everyone.
Bye, everybody.